I want to thank the organizer for this lovely lunch. I'm the entertainment. I'm sorry there is no band, it's just me. There have been a lot of studies going back from '89 to 1999. There were actually 16 major studies looking at stroke in patients with atrial fibrillation, taking either aspirin or Coumadin. I think if you come away with nothing else from this talk, right now Coumadin or warfarin is the treatment of choice, and it's clearly shown to be unequivocally better in preventing stroke compared to placebo with a 62% reduction, or aspirin with a 36% reduction. So when you see that patient on the floor with Afib and they start aspirin for stroke prevention, just remember it's not as good as warfarin. Aspirin is clearly more effective than placebo with a 23% reduction. There are two ways of looking at, or there are two scores that we use. One is the CHADS-2 score, which is this, and the other is the CHAD-VASC. And this is actually what's looking at what is the relative risk from stroke. And the CHAD score came from the Affirm trial, where they randomized one group of patients to Coumadin and rate control, and the other group to antiarrhythmic drugs. And the people that were felt to be staying in sinus rhythm were allowed to come off Coumadin. At the end of the study, there were more strokes in the rhythm control arm than in the rate control, and it appeared to center around a group of patients that had the acronym of CHADS. C is congestive heart failure, H is hypertension, A is age greater than 74, D is diabetes, and S is stroke. So you get 1 point for all of those, except if you have a stroke or TIA in the past, you get 2 points. Now, depending on what your CHAD score is what your adjusted stroke rate per year. So a CHAD score of 0 is 1.2, CHADS of 1 is 2.8, 2 is up to 4, 3 is 5.9, 4 is 8.5. You can see what 5 and 6 are. And that's what most people go by as the CHADS-2 score. Within the last 2 years, there's been a different score to try to improve on things, and it's called the CHAD-VASC score. And we'll quickly go over the CHAD-VASC. Again, there's congestive heart failure, hypertension, age greater than 74, you get 2 points, diabetes, stroke, and TIA. Sounds very familiar. And then the VASC part, if you got vascular disease, either peripheral vascular disease or aortic plaque, you get a point. You get a point for age 64 to 74. Unfortunately, if you're female, you actually get a point. And then if you look at what the points add up to, here's the adjusted stroke rate per year based on what the CHADS-VASC points are. And in general, the more points, the worse things are. Now, if anticoagulation had no risks, no side effects, no problems, it'd be easy. We just put everybody on it from birth and just continue it on. But as you know, there are risks with being on an anticoagulant. You have to take that into account when deciding whether we're going to anticoagulate somebody. And there's a new bleeding risk score called HAS-BLED. And this came out about 1.5 years ago. And the acronym is over here, the HAS-BLED. H is hypertension, you get 1 point for that. A is abnormal renal or liver function. So if you can get either 1 or 2 points for that. Stroke, bleeding, labile INRs, you get a point. Elderly, so anyone with a St. Petersburg address gets a point. And then drugs or alcohol, if it's drugs, you get 1 point, and if you indulging, then you get 2 points. So on the far side is what the risk factor, or what the more HAS-BLED points you have, the greater the risk of bleeding that you have. And so before you start anticoagulation, just keep this in mind as to what the risk of bleeding. So with all that taken together, what do we do? And the recommendations are, if you have a CHADS-0 score, then it's aspirin. If it's a CHADS-1 score, you can use aspirin or Coumadin. If it's a CHADS-2 score or greater, it's Coumadin. Now, if you've got a HAS-BLED score of 3 or above, then you really need to proceed with caution, and you need to reevaluate on a regular basis whether the risk of bleeding is not offset by the risk of stroke. So if you've got 3 points on a has bled score, be very cautious about anticoagulation, and you really have to give some thought about, should we anticoagulate, yes or no? Now, the biggest thing we're worried about with atrial fibrillation is obviously the risk of stroke. And when somebody presents with stroke, a lot of times we know that it's atheroembolic, which is plaque from the carotids, cardioembolic, which means that there's a clot and it came from the heart, whether it came from AFib or a patent foramen or a mural thrombus is unclear. Lacunar are small vessels, and that tends to be from hypertension. Other causes, such as intracranial hemorrhage, but we're still left 25 to 35% with cryptogenic, which means that we don't have a clue as to what caused the stroke. And that's where the dilemma comes from, because atrial fibrillation increases the older the person gets. And if you look at age ranges, what's the odds of somebody having AFib? So 18 to 64, 9.4, 65 to 74, 20, 75 and greater, you're almost a third are likely to have AFib, and greater than 85 years old, 41% have atrial fibrillation. Now, atrial fibrillation increases your risk of stroke by 5-fold. And the problem with strokes with atrial fibrillation is clots form in the atrial appendage, which is an outpouching within the atrium. When you're in a normal rhythm, it squeezes normally, but when you're in AFib, it sits there and quivers, and blood stagnates in the nooks and crannies of the atrial appendage. As a result, strokes from AFib tend to be a lot more massive than strokes from other causes. So a stroke from AFib tends to be incredibly devastating, and so it's really important that we not miss stroke from AFib. AFib can be paroxysmal and asymptomatic. A lot of patients that have AFib are totally unaware that they have AFib. So just asking them, do you feel palpitations, doesn't mean that they don't have AFib. 25% of AFib strokes have no prior known history of AFib. Strokes in people with known PAF occur in 50 to 70% of the time in sinus rhythm. So you don't have to be an AFib to have a stroke if you got AFib. The problem is how do we catch AFib? Does watching them for 3 days here on the monitor up on 7 West mean that they don't have atrial fibrillation as the cause? And no, the problem is AFib can be very intermittent. What tools do we have? We've got EKG Holters, external loop recorders, and we've got the implantable cardiac monitor. The problem with AFib and stroke is the more that you look, the more likely you are to find it. So if you only look annually, you're not going to find very much. If you start looking quarterly or monthly, you're going to find more atrial fibrillation. Here's a study where they had 149 people with acute strokes, and they underwent 24-hour Holter monitoring and then followed by a 7-day event recorder. And what you can see is as we go along, you have increasing episodes or increasing detection of atrial fibrillation. So this was after 7 days of monitoring, it's up to 16%. We think that with implantable loops, it may approach 30%. So if I watch them for 2 days and they don't have AFib, that doesn't mean anything. That doesn't mean that AFib is not the cause of the stroke. Why is it important to know whether AFib is the cause of the stroke? It's really important because if you've had a stroke, remember you've got to automatically have a CHAD score of 2. If you have a CHAD score of 2, we're already talking of warfarin. Aspirin or aspirin and Plavix don't cut it. So it's really important because once you get a CHAD score of 2 and above, we're already talking about Coumadin to make sure that atrial fibrillation is not the cause of the stroke. The risk of stroke is 4 times greater in patients with non-diagnosed AFib than those with known AFib. And the reason is, if we know that you have AFib, you're going to be on Coumadin, but if we don't know, you've got a much higher risk of stroke. So it's critically important that we figure out And again, the more you monitor, the more likely you are to find increasing episodes of AFib. So by the time you're at 12 months, if we were to do continuous monitoring, a third of those patients that present with a stroke actually are found to have atrial fibrillation. That's where the implantable loop recorder comes in. And here's the implantable loop recorder. And it's a little device that's about 4 inches long. We make a small incision under the skin and it slips right under the skin. And it's got a 3-year longevity, and what it can do is pick up evidence for atrial fibrillation. So in patients with clinical syndromes such as arrhythmias, or people with palpitation syncope, or if they've got a stroke that's unknown, we're now starting to put a lot more of these reveals in because of the devastation of missing stroke from AFib. We can monitor the patient's AFib burden, and even if they're asymptomatic. So that's the key. How well does the implantable loop recorder work? We can diagnose it 96% of the time, and if the loop says that there's no AFib, then you can take that to the bank. There's no atrial fibrillation. So if we put this in and there's no AFib, why expose the person to the risk of Coumadin? There was a cute little 85-year-old lady with a recent ischemic stroke of unknown cause. No history of syncope or dizziness. 72-hour monitor was completely normal. The EKG was normal. So obviously this lady's an aspirin because she doesn't have AFib. We've watched her for all of 72 hours. That should have diagnosed everything. So we put in the loop recorder, and after 11 days with a loop recorder, there's no atrial fibrillation detected on it. So our medications are Norvasc, aspirin, Plavix. But look here. Here's what we get. You notice that we put the thing in and there's no AFib, and then she starts having a ton of AFib. So this is a month out. She had no AFib, and then beyond a month, we detected AFib on that implantable loop recorder. And at that point, she got put on Coumadin. So she would have had to stay in the hospital for over a month on the monitor. And I know some patients seem to stay that long, but generally we don't recommend that. So clearly the loop recorder can document AFib. Think about it, particularly as you're getting the patients getting in older and older. They may have atrial fibrillation, and do you want to put an 85-year-old on Coumadin without evidence of AFib who's likely to fall? You've got to have a pretty good reason to put them on Coumadin. But to deny them Coumadin after they've had one stroke, the next stroke could be really devastating. The reveal is the device, and as I say, fool me once, shame on you, fool me twice, shame on me. We should not miss this stuff. Now, the device is MRI safe, so if somebody has a loop recorder, you can do a MRI scan. That's not a contraindication. I know that the X-ray techs will say we can't do it. Yeah, you can. There are alternatives to Coumadin, and one is Pradaxa that came out first. The other name for that is dabigatran. The second drug that came out is Xarelto, and within the last several weeks, apixaban or Eliquis has come out. We'll talk briefly about those. Pradaxa was the first one to come out. It's a direct thrombin inhibitor. The dose is 150 milligrams twice a day. For creatinine clearances between 15 and 30, the dose is 75 milligrams a day. The biggest problem with Pradaxa is about 10% of patients will get symptoms of acid reflux. Actually, if you were to do endoscopy, there's no erosion of the esophagus. It looks fairly normal, but the symptoms can be terrible. Even if you give them something like Protonix or Nexium, this can be a limiting issue in some patients. If somebody were to have an issue with bleeding and you were to stop the drug within 48 hours, it's completely out of your system, where if you were to stop Coumadin, it's going to take 4 or 5 days to get out of the system unless you reversed it with vitamin K or fresh frozen plasma. Now, if somebody is actively GI bleeding, remember that they're also bleeding out the active drug, so it actually washes out a lot faster. The only issue with bleeding, if it's intracranial, there are factor concentrates that people are using. It's not been, if you look at the package insert, it says that there's no approved way to reverse it, but it says in an emergency use the factor concentrate. There's no question that with Pradaxa you do have a higher risk of GI bleeding than with Coumadin. When I see an 85-year-old that we need to start anticoagulation, the first question I ask them, have you ever had GI bleeding? If the answer is yes, then I don't use Pradaxa, we use Coumadin. It can be reversed in an emergency with hemodialysis. And the other problem with all of these drugs is they tend to have a rebound effect, meaning if you stop the drug, they're at a slightly higher risk of embolic events than if they weren't on the drug. So all three of the drugs do have that rebound effect. Pradaxa is a direct thrombin inhibitor. The other two are factor Xa inhibitors. Xarelto is the next one we'll talk about that came out next. The other name for that is the rivaroxaban. The dose is 20 milligrams a day. The dose should be reduced to 15 if you've got creatinine clearances of 30 to 50 and should not be used with creatinine clearances of less than 30. There is an increased risk of GI bleeding compared to Coumadin. There is no reversal agent. Hemodialysis does not reverse rivaroxaban. The effect is gone in 48 hours. All of these agents, they're fully therapeutic within 4 hours, so the need for Lovenox/Coumadin goes away. You don't need Lovenox, just give them the pill and it's fully therapeutic in 4 hours. And you do have that rebound effect. The newest drug, which just came out last several weeks, is apixaban. It's also a factor Xa inhibitor. The dose is 5 milligrams twice a day. The dose is decreased to 2.5 if you have any of the two of the following: age greater than 80, body weight less than 65, creatinine 1.5. Unlike Pradaxa and Xarelto, this actually had a lower risk of GI bleeding than with Coumadin. I've not used this drug yet. It's just come out, but that may be a godsend to allow us to use it in elderly people with GI bleeding. There is an increased risk of thrombotic agents with stopping the drug. And again, there's no reversal agent, although in an emergency you can use the factor concentrates. The nice thing, again, with any of these drugs, if you're bleeding and you're bleeding out either in the GI tract or a gunshot wound bleeding out, you're bleeding out the active drug. So the effect goes away pretty quickly.
How long till it's out of your system?
Well, within 36 hours, it's completely out of your system. Now, there are alternatives to pharmacologic treatment to prevent strokes. And the first thing I'll just mention is catheter ablation. With catheter ablation for people with paroxysmal AFib with left atriums of less than 5 centimeters, we have a 95% cure rate. If you cure the AFib and we prove it with an implantable loop recorder you're not having AFib, then in people with CHAD scores of 2 and 3 after 3 months of an implantable loop recorder, I am stopping the anticoagulation. In people with CHAD scores of 4, I'm keeping them on it. There are lots of small little studies that confirm that if you cure somebody with catheter ablation, that it's safe to take them off anticoagulation. I need to warn you that there's no large randomized clinical control trial proving that. So I think if we do that, we need to be absolutely certain they're 100% AFib free with either a pacemaker or an implantable loop recorder. But there are a lot of small little studies that do suggest that. Now, when people have AFib and we want to do an electric cardioversion, what we do is we do a transesophageal echo, and what we're looking for is clot within the atrial appendage. The atrial appendage is a blind pouch where clots form, as I said. So if you eliminate the atrial appendage, it does appear that you can eliminate the risk for stroke. And there are really 4 ways to eliminate the atrial appendage. The first is in surgery oversewing it. So the surgeons will put some pledgeted sutures on the outside of the atrial appendage and oversew it. The other thing in surgery is there's a clip called an AtriClip, which looks like a really strong paper clip, and you put it on the appendage and it clamps down, and if you're not happy with the location, you can reposition it. The third is the Watchman, and we'll talk about that in a minute, and the fourth is the Lariat. I have a Watchman here I'll pass around. Please don't pull it back into the sheath, or please don't disengage it. and I do need it back at the end. It's not FDA approved, so we can't let it wander around. Here's the how the Watchman works. What we do is we go in the left atrium, we inject some contrast, and then we deploy this device here, which has got a mesh cloth, so any clots in here can't get out. There are barbs that hold it in place, and if we're happy, we unscrew it and leave this permanently in place. And what happens is your body encapsulates this in scar tissue. We were one of the centers that actually implanted the Watchman under clinical protocol. I have about 6 or 7 patients with Watchmans in place. The Watchman hopefully will be market released about a year from now. The Watchman is nice because if you eliminate the atrial appendage, even if you're in Afib, you don't need to be on anticoagulation. The problem with the Watchman is it does leave a foreign object behind, and you have to be on Coumadin for about 45 to 60 days until your body starts encasing it in scar tissue. So you still have to be on anticoagulation for a little bit of time. The next device is the Lariat, and before we proceed, there's a quirk in medicine and the FDA you need to realize. The oversewing and the AtriClip and the central heart were approved under surgical codes. If you approve it under a surgical code, you don't need to go to the FDA to prove safety and efficacy. The Watchman went under a medical code, and they actually did a randomized clinical trial. It was a small little company called Atritech in St. Paul, Minnesota. And what the FDA said was, yeah, we agree it works. It was a study looking at people with positive CHAD scores. It clearly had less stroke and less hemorrhagic stroke than warfarin. The FDA wanted to be labeled for Coumadin intolerant patients. Well, if you're a tiny little venture capital company doing the Watchman and you're looking to sell out for multi-billions of dollars, if the FDA limits your indication to Coumadin intolerant, it's not going to be as much money as if they said anyone with atrial fibrillation and a positive CHAD score. So long and short, the company agreed to repeat the clinical trial, and if they got the same results, then they were going to get labeling for positive CHAD score. In the interim, they've been bought by Boston Scientific. The new study should be sent to the FDA anytime, so essentially a year from now the Watchman will be out. Until the Watchman is out, we have no randomized double-blind clinical control trials showing that appendage closure is better than warfarin. As a result, right now there's not a CPT code for closing the atrial appendage, whether it be oversewing, whether it be the AtriClip, whether it be the Lariat, or whether it be the Watchman device. And so right now we've done 1 Lariat. We've done 6 Watchmen, but that was under an FDA-sponsored clinical protocol. But we've done 1 Lariat. I doubt that it will get paid for. I've got another patient who's actually a team member of a BayCare team member who really needs his appendage closed. And we're in the process of pleading with Cigna and also BayCare to see if they'll let us close the appendage. That being said, the other way to close the appendage is the central heart. And the central heart has several products with it. The first is the Lariat Delivery, and you'll notice at the bottom this little device is actually the Lariat. And here it's fully expanded and here it's cinched down. This is a little plastic tube, but inside this plastic tube is an Ethibond suture that when we're happy with the location, we actually permanently cinch it down. We actually have 2 sets of magnets that come with central heart. One we actually put inside the pericardial space, one within the atrial appendage, and get them to hook up, and this acts as a rail to get that Lariat to go over the appendage. We also have this balloon catheter we put in the atrial appendage, and we position it right at the mouth of the appendage, so as we snare down the Lariat, it closes right at the mouth of the appendage. It comes with this soft 12 French sheath we shove within the pericardial space. That's always an exciting moment. This device will tighten the knot, and this one will actually cut the suture at the end. Now, the way you do this is we first get a CAT scan to make sure that the appendage is the appropriate size. About half of the patients will have an appendage that's too big. They also have to have a virgin pericardium, which means no previous open heart surgery, no pericarditis. And what we do is we stick a needle under the breastbone, and as you stick it under the breastbone, you can actually see the shadow of the heart here, and you can approach the heart, and as you approach the heart, you can actually feel it tapping on the needle. At that point, we inject a little contrast, and you see the tenting of the pericardium, which is the sac around the heart. And then you actually pop through that sac, and we put a guide wire. And it's really important that the guide wire go all the way around and on both sides of the spine, because it is possible when you pop that needle into the space, it can actually pop into the right ventricle. And putting a guide wire through the wall into the right ventricle is not a big deal, but putting a 12-French sheath through the wall of the right ventricle is a big deal. So we get into the pericardial space, and after we're happy there, then at that point we go up through the leg and we go transseptally across the intraatrial septum into the left atrium. And what we do is, you can see, we inject contrast, and here's the atrial appendage. At that point, what we're going to do is we're going to advance this sheath into the pericardium. And from inside, we have a magnet that's sitting right here at the very tip of the appendage. And you'll notice we'll put another magnet that actually goes in through the sheath in the pericardium and hooks up with the pericardium. So here's that little balloon catheter, and you can see it right here at the mouth of the appendage. We're positioning it. And now what we're going to do is, here's that second magnet, and we're going to get it to hook up. So now it's hooked up within that pericardial space and in the appendage. And at this point, we slide the lariat over that wire going into the pericardial space. So we put it in through the sheath. And it can be a challenge to get it slide over that rail without disengaging the magnets, but it really wasn't too bad. And now you'll notice that here's that lariat right here. It goes all the way around, and it's actually over that balloon which is sitting at the mouth. And at this point, you'll notice that we're closing that lariat and snugging it down right at the mouth of the appendage, and we're looking on transesophageal echo to make sure that we've closed the entire appendage. The nice thing about that lariat is, as you push it up, it will hit the wall of the atrium, so it actually grabs it right at the mouth of the appendage. It does an amazing job of getting to the appendage. And now you can see that the appendage is closed, and we've injected contrast, and you can see that it's completely sealed off at this point. So at this point, what we do is we deflate the balloon, and then we actually pull it out. So we've deflated the balloon, and now we pull this thing out. And now at this point, we'll deploy the suture. So in a minute, he's going to pull right back here, which is actually the suture that's now disengaging from that plastic ring and tightening down on the atrial appendage. And at this point, we widen that plastic ring, and we actually pull it off the appendage. And this is a little device that will actually tighten the suture. It's got a little spring here so that you pull it to a certain tension, you wait 5 minutes and do it again. And that way the knot is cinched down. The first time you cinch it, it actually kind of occludes the blood supply. And then 5 minutes later, you can actually cinch it down a little bit more. And then you can see here's the before and here's the after. So the appendage is completely amputated. The nice thing about this is it doesn't leave any foreign objects within the sac, where the blood supply can get it. So somebody who has intermittent bacteremia, this isn't a problem. They go home without any anticoagulation, unlike the Watchman device. As I said, you do need a virgin pericardium to do it. And you'll see, here's the appendage before, and this is where clots form, and you can see here it's completely closed off. The gentleman we did was a guy that had 3 strokes, eventually got put on anticoagulation, and then started having GI bleeding. So he was between a rock and a hard place. And we closed his atrial appendage with a Lariat device. At that point, there's a suture left behind, and you just go in and you snip the suture. So you'll see it following along the suture, and right there he just snipped it. And we leave a pericardial drain in place overnight. Patient goes to the unit till the next morning. We pull the drain, and then they go home. The biggest issue with it is a lot of patients do have pericarditis from it, and so we do give colchicine. We don't like to give steroids because we want this to heal in, and steroids may prevent it from healing. But that's the Lariat device. We've done one. We'll probably do one in the next several weeks. And I think once the Watchman gets FDA approved, then all of a sudden proof of concept occurs. And at that point, we'll be doing a lot of appendage closure. I hate Coumadin, you hate Coumadin, we all hate Coumadin, and this is an option off of Coumadin. Thank you very much for coming.